the YouTube channel, so just give me a minute. Let's see if the chat function is functioning. Do you want to put some messages on the chat function? Just tell us where are you logging in from today? Let's see if this works. Sorry, I'm just not at home today. We're in Vienna. We just finished the St. Gallen's conference. It was a great conference today. So uh, that's why I'm just logging in from the hotel before going back home. So since quite a few messages online, that's great. So good evening, everyone, and welcome to the iBreast Book webinar. I think we're on number 71 now, isn't it? So well, it has been 5 years since we started, or just 4.5 years. And it's great to see there's still appetite for those webinars. We have slightly lower registration today because it's Ramadan, so many people are breaking their fast at this time. And also, it's St. Gallen's conference. We had about 4,000 or 5,000 people here in Vienna for the conference today. So many people are going home today, so will not be able to join us. But still, we have about 300 people online today. We decided to do things differently this time. So we have three areas that are still controversial, and I think there's lots of questions that we'll not be able to answer, but we thought that we'll bring those things. Many extent of surgery after primary systemic treatment, surgical and oncological outcomes of the breast after using MRI scans, and topical estrogen therapy in ER positive breast cancer survivors. What's the evidence, if there is any evidence? And those areas we always argue about in the MDT in clinics, and we have exposure to the patients. So we have great speakers today. We have Antonius Valachis from Sweden. We have Kristelin Gallagher from the States. We have Andreas Karakatsanis from Sweden. Peter Barry couldn't join us because he's on the plane now going back from St. Gallen. Theo Fukakis from Sweden, and of course we have Lila Castora from England, and we have the lovely Ricardo Pardo. He's going the Spanish channel, and we have Tatiana with us today for the uh, Russian channel. So if you want to listen to things in Spanish and or in Russian, you can just choose the channel. Please, this time what we'll do, because they're different talks, they're different topics, we will do the 15-minute talk, and then we will do the questions, and then we go to the next topic. So we'll take about 1.5, 2 hours for everything. The first talk will be Antonios Valachis from Orebro in Sweden. He's going to talk about extent of surgery after primary systemic treatment. And we have that discussion always. Somebody has neoadjuvant chemotherapy, they have complete response, and they will want to see what is the extent of surgery we're going to do. Before we do that, there's little polls. We're going to try this first time doing polls to see what's your thoughts before and after. So if I give you a minute to do the poll. These are three simple questions. So if you have time, please have a look at that and answer the questions for me. So the first is about primary systemic treatment is known to facilitate de-escalation of surgery. Do you believe that this is proportionally utilized? It's a simple yes or no. And the second thing is modern drugs come with higher PCR rates, and we know that we have complete pathological response in much more patients now. Should this be expected to translate to de-escalation of surgery? So the more uh, radiological response you have, are you going to conserve more breast? Is that what you'd expect to see from the literature? And the third one, you can use uh, as many answers as you want. What would you the escalation of surgery, as in would you consider conserving the surgery if it wasn't conserved pre-chemo in large multicentric multifocal cancer, if there's extensive microcalcifications in women under 40, in locally advanced disease? So if this is one of the options for you, you tick it. If it's not an option, don't tick it and just leave it as none of the above. Or if you don't tick anything there, that should be fine. I think I must have done something wrong here. I should have put that an option of none of the above, because It's expecting you to put an answer. If it's too late to fix that. In the post poll, I'll see if I can do a correction on that. So we have about not only half of you. So if we get at least 50% of you to answer the questions, because many of those questions we'll put them after and see if there is any change in your thoughts after we see the literature. So if more of you can answer that, that will be great. I think for people that have joined, please it will take you less than a minute to do the poll. We will close the poll in the coming few seconds. And for now, if you, Antonius, while people are still voting, do you want to start sharing your screen? Because Antonius Valakis is going to talk about the extent of surgery after primary systemic treatment. Antonius, do you want to? Perfect. So whenever you're happy to start, we'll end the poll.
Okay, I'm ready.
Yeah, that's great. So we'll end the poll here. I'll just leave it open until while you're talking, and then I'll stop it in a couple of minutes. Go on, Antonius.
Thank you, Yazan. So my name is Antonis Valachis. I'm an oncologist, actually. I'm going to talk about the extent of surgery after primary systemic therapy, let's say neoadjuvant therapy. And I'm going to present unpublished results from a meta-analysis that summarizes the prospective evidence. So I'm going to talk on behalf of the working group that work with this meta-analysis. You see here some well-known persons. So just the context, as we know, neoadjuvant therapy has gained more, let's say, evidence the latest year as the preferred treatment option, especially in HER2-positive or triple-negative disease. And this is related to the fact that there are some advantages with the treatment as neoadjuvant that we can, let's say, classify to emerging or traditional. And some of the emerging advantages are the fact that we can, based on the response to the neoadjuvant therapy, choose better post-neoadjuvant therapy. And we know that from GREAT-X, we know that from Catherine study, we know that from Olympia study as well, with olaparib in germline BRCA mutated patients. We know also that in some treatment strategies, it's better to give them when we have the tumor in place, as for instance, in immunotherapy, we know that it's better to give the treatment as neoadjuvant compared to adjuvant. And we have also the situation where we have patients with exceptional response to neoadjuvant therapy when we might not need even to perform a surgery. And then we have the traditional one, the traditional advantage of the possibility to de-escalate the surgery to the breast. And this is what we need to discuss today, if this is really the case in the evidence. And this is the background of two meta-analyses that were published several years ago. The first one is from Andreas Karakatsaanis and colleagues. They found that it was about 31% of the patients who became eligible for breast-conserving surgery after neoadjuvant therapy that underwent breast-conserving surgery. So we had quite a lot of patients that did not get a de-escalate surgery. And the same year, meta-analysis by Carmen Crisitello and colleagues, they included, as the previous meta-analysis, only randomized trials. They tried to find if there was a correlation between PCR and the rates of breast-conserving surgery. What they found, and you can see in these scatter plots, is that there was no such correlation. So if we can, let's say, conclude for this meta-analysis, we can say that neither clinical complete response nor PCR are associated with more breast-conserving surgeries. And the question here is why we cannot see an increase in breast-conserving surgery after neoadjuvant therapy. And one can argue that it is mostly the clinical assessment done before the neoadjuvant therapy that matters for the surgeons. It can be also factors associated with the tumor or the response, for instance, multifocal disease or microcalcifications that are difficult to interpret when you see them after neoadjuvant therapy, maybe an equivocal radiological response as well. But it can be also so that it can be the perception of the surgeon that there might be a higher risk of recurrence after neoadjuvant therapy and breast conserving surgery. The situation can be more difficult in the future, or let's say now, because we have more effective neoadjuvant therapies that lead to better responses. So if we have this discrepancy, we're going to have even more patients that are missing the opportunity for a de-escalating surgery. And another problem we have is that the classical, let's say, neoadjuvant trials, they are not collecting information about surgical outcomes. So we do not have the possibility to somehow dig into the problem and try to understand it. So what I'm going to present today is a up-to-date pooled analysis of all prospective evidence on the association between response, either clinical or pathological, and breast conserving surgery after neoadjuvant therapy, and explore the influential factors for this association. So what we did was a systematic review, three electronic libraries were searched, and we identified randomized controlled trials or prospective cohort studies, used any type of neoadjuvant therapy that provided baseline surgical assessment for breast conserving surgery eligibility and the actual procedure afterwards. We analyzed the patients per protocol because we would like to have the patients treated with neoadjuvant therapy and after surgery, of course. We did some assumptions when we didn't have information about the eligibility for breast conserving surgery after neoadjuvant. We used the clinical response rate of more than 50% as, let's say, a surrogate for eligibility to de-escalation. And we did some comparisons that I'm going to show to you today, where we compare the eligibility for breast conserving surgery before and after neoadjuvant, the eligibility for breast conserving surgery after neoadjuvant compared to actual surgery done, the eligibility for breast conserving surgery before neoadjuvant compared to the actual surgery, and the PCR rate per type of surgery. And we performed as well some analysis to better understand the potential difference in the associations. So we identified in total 16 studies, including 4,670 patients. And as you can see, when we looked at the protocol and with the numbers of the patients with complete surgical data, we missed some patients, but we still had quite a lot of patients, let's say, to do the analysis. So more than 4,000 patients. 9 of the studies included patients receiving chemotherapy with or without targeted therapies, and 7 with endocrine therapy. Here you can see the flowchart, quite busy slide. What I would like to show here or to highlight is that we started with approximately 2,000 studies. We ended up with 16, and we missed quite a lot. You see, we had 132 studies that we assessed with a full text, and we missed their 100 studies because we didn't have information about the baseline surgical assessment. So this showcase the problem that we do not have so much information about surgical outcomes in neoadjuvant trials. So the results, here we have the comparison between, let's say, patients that were eligible for breast conserving surgery before the neoadjuvant treatment and after the neoadjuvant treatment. As you can see, the poor proportion for the patients eligible for breast conserving surgery before neoadjuvant, it was 44%. It went up to 70% after the treatment, with a risk difference of 23.9%. So let's say 23.9% of patients were eligible for, more patients were eligible for breast conserving surgery after neoadjuvant therapy. So this is what we gain, let's say, with neoadjuvant therapy. We didn't find any difference in terms of the time of the patient inclusion or the time of the publication. So no change over time, no difference in terms of the type of treatment. We found a more pronounced difference for HER2-positive disease compared to luminal or triple negative. And apart from subtype, the initial eligibility for breast-conserving surgery was also associated factor for the risk difference. When we look on the second comparison, let's say, here we have patients that were eligible for breast-conserving surgery after post-neoadjuvant therapy, and then the patients that were actually underwent breast-conserving surgery. So here we have the pool proportion of patients that were eligible for breast-conserving surgery after neoadjuvant therapy of 17.8%. And when it comes to the actual numbers of patients performed breast-conserving surgery, we have 55.2%. So the risk difference here is 15.1%. And that means that we missed the opportunity for a de-escalation in 15.1% of the patients. The risk difference was less pronounced in patients treated with endocrine neoadjuvant therapy compared to chemotherapy, but we didn't find any change over time. So we couldn't see that this trend was better over time. So we still have a group of patients that we do not treat with de-escalation, despite the fact that we could. The third comparison is about the patients eligible for breast-conserving surgery before the neoadjuvant therapy, and comparison with the actual breast-conserving surgery done. So this is what we gain in real life, let's say, according to the studies. And here we have the proportion of patients that were eligible for breast-conserving surgery before neoadjuvant. It was 44.2%, and this was up to 55.2% when it comes to the actual breast-conserving surgeries performed. And this difference we see here is about 6%, and it's not statistically significant difference. Here we could see somewhat higher risk difference when we use neoadjuvant endocrine therapy with a time trend as well. And the only factor that was associated with the risk difference in our analysis, it was the eligibility of breast-conserving surgery at baseline. The final analysis was about the pool PCR rates, let's say, between patients underwent mastectomy compared to breast-conserving surgery after neoadjuvant therapy. And what we saw, it was that the probability of PCR among patients treated with mastectomy, it was 38.5%, and it was 54.9% for patients treated with breast-conserving surgery. We didn't find, though, any statistically significant risk difference between these two proportions. And what we can see as well is that we do not have any change for this association over time. And we see quite a lot of patients that have a PCR and have undergone mastectomy. We tried also to see if there are any qualitative data about factors that are associated with the decision to de-escalate the surgery. 9 studies of the 16 had some information about that. 5 of them discussed about the fact that there might be multifocal disease or 2 large tumors, 4 about patient preferences, 3 about contraindications to postoperative radiotherapy. And this is, as oncologists, this is something that it's always quite fascinating to see, because we do not have so many situations when we're talking about contraindications to radiotherapy in general. Poor cosmetic outcomes in 2 studies, BRCA status in 1 study. And we didn't find any study mention type of response as one of the reasons. So just to summarize before the discussion, we need to remember 3 numbers. We have first the potential benefit of neoadjuvant therapy in the escalation of the surgery, and this is 23.9%. So 23.9% more patients become eligible for breast-conserving surgery after neoadjuvant therapy. So this is what we can get as a benefit. We have also the missing opportunity for surgical de-escalation. 15.1% of the patients were eligible for breast conserving surgery after neoadjuvant therapy, but they did not undergo breast conserving surgery. And then we have the actual benefit of neoadjuvant therapy. And this is 6% with a non-statistically significant difference here. So 6% more patients from those that were eligible for breast conserving surgery before neoadjuvant therapy underwent breast conserving surgery after neoadjuvant therapy. So we see a benefit that is quite large, a missing opportunity that is also quite large, and the actual benefit we gain is quite small. So I leave you with a picture of the castle in Erebro, and I have on purpose not discussed about the clinical implication or the future direction, because I think this is something for our discussions. Thank you.
That's great talk and up to the point, Antonios. So do you want to stop sharing screen and let's do a bit of discussion. Let's talk a few things. I don't think there's many questions on the Q&A section. So if all the rest of the panelists, you want to open your cameras, that's great. Andreas,
Yes.
let's start.
So,
Any thoughts about the talk?
so I think that the most interesting thing with regards to that, in my head, there are three things that are important. The first one is what Antonis highlighted. We found approximately 112 randomized controlled trials or prospective studies that are looking into primary systemic therapy for operable breast cancer or non-metastatic breast cancer, but only 16 of them had a baseline surgical assessment. So we do not know what we do not know. 90% of the data is never there. The most interesting thing is that even those studies, they just mention on a table BCS eligible at presentation, but there is no rationale on how this decision was taken. And we know that for us surgeons, there is not really a very clear technical cutoff as to when you could do breast conserving surgery or when you should only resort to a mastectomy if you have non-inflammatory and non-hereditary breast cancer. So this is a missing opportunity, and we need to kind of integrate that in our way of thinking. The other thing is that you have a 24% benefit and you make use of 1/4 of it. So 3 out of 4 patients who downstage enough still undergo a mastectomy. And as Antonis showed, approximately 40% of them, and this is also in line with observational retrospective data, 4 out of 10 mastectomies are blank mastectomies.
So
And this is also something that we need to discuss, I
I think
think.
there's a couple of points that I find because I sit on few MDTs and sat on different MDTs. In the old days, sometimes the MDT will say, we'll start with neoadjuvant chemotherapy, and the patient will need a mastectomy, whatever the response. And that's still common practice in many places. So really, we're just giving the chemotherapy, but we're going to do the mastectomy anyway. You see the argument in gene positive patients and some high risk patients, but in the majority of patients, there is no argument to do that. The other thing is some of the criteria that mentioned, like multifocality, multicentricity, and the amount of calcifications, which you can see the challenge, and there's not enough data to change people's minds on those things. Either you believe or you don't believe, and I don't think you'll ever have RCTs to address those. Third of all, I think in some MDTs, radiologists or people that are not surgeons try to take surgical decisions, which does not always help. Crystalline, anything that happens differently in your MDT, or do you see the same problems also?
I think we see some of the same problems, especially when you have persistent radiographic abnormality and you don't know what's what, and then you have to remove it. Certainly, at the US, we are doing more multi-lumpectomies, kind of in a patient to do breast conservation. And so even if a patient is multifocal or multicentric, but there's far enough away and there's good, healthy intervening tissue, we're much more likely to attempt a breast conservation procedure since they're going to get whole breast radiation afterwards.
And the other thing is that, may I ask that to Theo, because oncology has a lot to say, but they don't always say lots in the MDT, unfortunately. Different pathologists behave differently. And if you have even if it's complete or near complete radiological response in an ER positive tumor, I'll still sometimes be a bit, ooh, am I going to take the clip? I'm going to take the whole footprint. But if you have a triple negative or HER2 positive, if you have a complete response, I'll be very comfortable just to take only the clip. So in some MDTs, that does not happen. They just don't look at the biology and the expected response. Any comments on that, Theo?
Yeah, I think oncologists, traditionally they don't interfere so much with the decision historically, but I think that has changed during the past years, and I think that has to do with the planned post-neoadjuvant therapy, and it's not only radiotherapy that is the classical thing that we like to discuss, and whether the patient should receive or should not receive radiotherapy. But now, given the opportunities for adjuvant treatments that have changed, I think that oncologists generally have become more aware of what happens to the patient when they come to us, and if the type of surgery they have received affects what we will do with them afterwards. So I think, and this is something that is not easy to see in the meta-analysis, but I think that in this trend, there should be some temporal trend that if it's possible to identify or to study, that would be very interesting. So I see the results. I'm a bit concerned about the results as they are, that the meta-analysis shows. But I mean, this is how it is. So my question then would be the follow-up question: has it been any change? Do we see any temporal trends on this, or is it the same?
Okay, we would not reveal that, but we can tell that. So actually, we have a secondary analysis that Antonis has not shown, where we are kind of comparing on a trial level the on a cumulative model path CR rates for chemotherapy trials, of course, because in endocrine therapy that would not be relevant, and mastectomy rates, and the relevant increase is larger the more that recent the trial is. And that means that we have more efficient drugs and we get path CRs that exceed 60% sometimes, but the mastectomy rate is the same. And it would seem that the patient's fate is decided by that first surgical assessment at baseline, and that does not change.
And we see that not only in surgery, in all local treatments, Andreas. So you see that the decision making on radiotherapy is also based still on initial size of tumor, initial grade of tumor, initial axillary staging, and there is no data to suggest that we can de-escalate that. And so lots of things are decided on the first presentation. But for example, for us, I think once you see that amount of response, there is evidence that there is response, or there is no response on radiology. And if we excise it and it's out, then it's out. But some people are still uncomfortable and they just remember, they just act on an image that was seen before. There's certain things that I will be uncomfortable with, like inflammatory cancers, like certain types of tumors, that I think they still need to have a mastectomy, but that's not the address. We're not going to address that here. But always, think when you make your decision making, remember the biology. I'll be a bit more concerned of lobulars. Still, some people will give neoadjuvants for not positive lobulars. I don't think this works. Also, uh, for ER positives, I think the response will be a bit more Swiss cheese response. But most of your patients that you're giving is triple negatives, HER2 positives. With a new medication, you're getting path CR of 60, 70%, and you're ending with a mastectomy that the pathologist will have a headache trying to find where the tumor was, and sometimes they don't find anything other than the clip, if they find the clip. So we need to tailor the surgery according to response. It's a risk adaptive surgery. I've shared the post. Paul, please answer, as many of you, please, if you can answer that. And please, I've added an extra question. How is different from your answer before the talk? If you can put, even if it's a line or two, says you feel that you should do less, you should do more, you feel that you should be planning your surgery based on the post chemo, even if it's a little comment, that will make a difference, because we're looking at making those webinars a bit more interactive and changing things slightly to get the most, both you and us, because we'll learn more about what you need, and you learn more from answering those questions, I think, sometimes. Just final comments.
Well,
Final
yeah,
comments.
while the people are voting with regards, Theo has raised his hand. Theo.
Yes, just I mean, now that Andreas, that you commented on the temporal aspect, I think without knowing it in advance, I think that it makes sense because of the indication for neoadjuvant therapy that has changed. Like if we go to the past, the indication of being able to do a breast conserving surgery was one of the main factors why patients received neoadjuvant therapy. Well, this has changed when the post-neoadjuvant trials came out with positive results for triple negative and HER2 positive. Now, what we tell the patients is that we want to improve their prognosis, long-term prognosis. So the downside of surgery is not the main thing when we initiate a neoadjuvant treatment. So yeah, I think it makes sense that that we don't exploit the.
I think that you have a point there, but from a completely practical standpoint, I think that one major barrier is that the dissemination of knowledge. So, for example, what Crystalline described, there is a pooled analysis from GEPAR-3, Quarto, and FEMTO on multicentric tumors excised with separate lumpectomies, where they showed that if you had path-CR or negative margins, it was the same thing in terms of local recurrence and survival. It's just that we need to kind of open ourselves to the opportunity. The other thing is that we know that calcifications, they are more or less tombstones. Now we have more and more emerging reports in the literature that show that their presence is completely not non-specific. And deciding on your footprint or the type of surgery based on microcalcifications is usually the flip of a coin. Whereas we know there are early data from MD Anderson that suggests that the higher the Ki-67 in the invasive component, the more probably you will see path-CR. But I think that we need to find our work to work our way around it. And yes, now we are talking about what we are doing, but until now, the only study that attempts to understand the extent of surgery by measuring it and not by just some decision is Ariadne.
And people are asking, so people are not seeing the poll. If you just click on the poll and quizzes section on the lower of your screen, if you cannot find it, click on the more, you'll find it. And the last couple of minutes, because 160 of you has already answered the poll, which is great. If we can get some more, that will be better before we go to the next talk. Any final comments from Antonios or from Theo or from Crystalline before we go to the next talk? Perfect. So lots of things to learn from here, and we'll go to the next point, and the next speaker will be Crystalline Gallagher. So Andreas will introduce Crystalline, but before we do that, I'm going to close this poll and start a new poll, if that's okay with all of you. We'll bore you today with a bit of polls, and we'll share the results of this one. And now the next talk is about MRI scan, use MRI scan in surgical planning, really.
Okay.
And we'll give the microphone to Andreas to introduce the next speaker on the topic.
So we are very happy to have Professor Crystalline Gallagher with us. Crystalline is the Chief of Breast Surgery and Breast Surgical Oncologist from Chapel Hill in North Carolina. She will be talking to us about the surgical and oncological outcomes when a preoperative breast MRI is performed. So thank you very much for accepting to be part of this, Crystalline. Let's start with the poll with that.
So the poll is online. If you cannot see it, just click on the poll or the quizzes. It's 3 simple questions. Do you believe that preoperative MRI scan can help reduce re-excision rates in breast-conserving surgery? Do you believe that preoperative MRIs can reduce the risk of local recurrence? And in a patient with lobular carcinoma, would you primarily do a pre-op MRI scan based on certain criteria? We've put the 3 criteria for you to choose from. And we'll leave that poll on while Crystalline starts her talk. We have about 100 people answering. We'll repeat the poll after the talk, see if you change your mind a bit. So, Crystalline, do you want to start?
Yes. So thank you to the moderators for this invitation. It is an honor to be here today and discuss the role of breast MRI in optimizing surgical and oncologic outcomes in breast cancer. I'm going to present some of the current data, and then again, we're going to be taking another poll to see if this changes your opinion when ordering MRI for your surgical workup for your patients. I'm going to try to cram a lot into 15 minutes, so we'll see how this works. The integration of MRI in breast cancer management has been the topic of considerable debate, with important implications for tumor staging, treatment response assessment, and surgical decision-making. Evidence on indications and outcomes of preoperative MRI and upfront surgery are unclear. There is wide variation in practice patterns, but with weak evidence. Invasive lobular, multifocal, multicentric cancer, and dense breast tissue are very common indicators for MRI use. And really the goal today is to review the current evidence and implications for clinical practice. Just some general objectives. We're going to hopefully give you an understanding of MRI's role in surgical decision-making, how to evaluate MRI accuracy in post-neoadjuvant treatment and what the data is surrounding this, to assess MRI's impact on surgical outcomes, and then finally to discuss invasive lobular specific findings. MRI has been shown to have a higher sensitivity than mammogram for cancer detection, more than 90%, but really a variable specificity. It's been shown to increase identification of ipsilateral and contralateral malignancies. So this is one potential reason that you might consider an MRI. Another is detection of additional lesions. In 2008, a meta-analysis by Husami et al. Reported just over 2,500 patients with breast cancer who underwent MRI. Additional disease was identified in about 16% of the patients, with a range of 6 to 34% in this series. Many people use it to evaluate neoadjuvant treatment response. And then the question comes up, is this really better than other modalities? And we're going to talk about that today. And then finally, what is the influence on surgical planning? We know that it's been associated with altering surgical plans in about 15 to 30% of cases. Many trials have shown this, or many studies. And while it may reduce re-excision rates, it's also been well established that it significantly increases mastectomy rates. Understanding the accuracy of MRI in predicting residual tumor burden after neoadjuvant chemotherapy is crucial for surgical decision-making. A comprehensive meta-analysis by Marinovich in 2013 with an update in 2015 included 19 studies and 958 patients. They compared mean differences in tumor size between MRI or other comparator tests, and pathology was pooled by assuming a fixed effect. Limits of agreement, or LOA, were estimated from a pooled variance by assuming equal variance of the differences across the studies. As shown in this forest plot, the MRI slightly overestimates the pathological size with pooled mean difference of 0.1 centimeters. But as you can also see, the measurement errors were noted to be very broad. They compared MRI to both ultrasound and mammogram and found that MRI and ultrasound had a very similar accuracy. When comparing mammogram, they found that mammogram actually overestimated tumor size more often than MRI in the neoadjuvant chemotherapy setting. They concluded that MRI appears slightly overestimate pathologic size, but measurement errors may be large enough to be clinically significant. The other comment that I wanted to make that I don't have the graph is they also compared it to physical exam. And again, both mammogram and physical exam overestimated tumor size when compared to MRI. This study by Vrijns et al., published in the European Journal of Cancer, compared the accuracy of ultrasound and MRI in predicting residual tumor size post-neoadjuvant chemotherapy in 182 breast cancer patients. These were from the INTEND study, and they used histopathologic size as the gold standard. They found that ultrasound correctly estimated tumor size within 1 centimeter in 63% of cases, compared to 54% in MRI. They had similar over and underestimation rates, with overestimation being more common in more aggressive subtypes, such as triple-negative breast cancer and HER2 overexpressed cancers. Neither were excellent at estimating pathologic complete response, and this was particularly present in hormone receptor positive tumors. The authors concluded that ultrasound was at least as good as MRI in providing information on residual tumor size post-neoadjuvant chemotherapy. So what about MRI in the upfront surgery setting? Many studies have shown that the receipt of MRI in patients with breast cancer is an independent risk factor for receiving mastectomy, even when adjusted for stage and tumor characteristics. And so the big clinical question is, how does an imaging modality translate into clinical benefit? And we really want to look at surgical outcomes, but then also oncologic outcomes. In 2013, a meta-analysis by Husami et al., published in the Annals of Surgical Oncology, evaluated the impact of preoperative MRI versus standard assessment or no MRI on surgical outcomes in just over 3,000 women with newly diagnosed breast cancer. This was across 9 controlled studies, which were 2 randomized controlled trials and 7 comparative cohorts. Key findings showed that preoperative MRI significantly increased mastectomy rates, with initial mastectomy rates rising from 8.1% to 16.4%, and overall mastectomy rates from 18.2% to 25.5%, without reducing re-excision rates after breast-conserving surgery. In lobular cancer specifically, in that subgroup of about 766 patients, MRI increased the initial mastectomy odds as well as the overall mastectomy, while weakly reducing re-excision rates, though at the cost of more mastectomies. This study suggested an unfavorable harm-benefit ratio for routine preoperative MRI in breast cancer and questioned its value in improving survival outcomes. The study by Cozy et al., published in the European Radiology in this past year, analyzed the impact of preoperative MRI on surgical outcomes in 1,000 women with pure unilateral DCIS, diagnosed with core needle biopsy or vacuum-assisted biopsy from the MIPA study. This compared 507 patients who underwent MRI and 498 who did not, and they refined the comparison with a 1-to-1 matching to adjust for 8 confounding covariants. Key findings from that match cohort revealed that the MRI group had a significantly higher first-line mastectomy rate, 20% versus 11%, but a substantially lower reoperation rate at 10% versus 22%, yielding a 2.53 odds ratio of avoiding a reoperation, while the overall mastectomy rate was non-significantly higher. These results suggest that a preoperative MRI increases initial mastectomies, but more than offsets this with reduced operation, potentially offering a net positive impact on surgical outcomes for DCIS when other biases are controlled. However, long-term clinical relevance really requires additional investigation. So kind of a take-home message here. There is no convincing evidence that MRI significantly reduces re-excision lumpectomy rates, especially for invasive cancers, including invasive lobular carcinomas, local recurrence, or overall survival patients with either invasive or DCIS. Certainly, there are considerations for special circumstances. If you have an axillary metastasis with an occult breast primary, that's a good time to think about doing an MRI. Patients who have Paget's disease and an unknown what else is going on in their breast, you can look for additional findings in the breast. Again, a consideration would be lobular pathology, but really I kind of use this, at least in my practice and based on the data, if it really has a significant imaging discordance with other imaging modality or exam where MRI may be helpful to screen for an unknown primary to delineate extent of disease, or if I'm thinking of multicentric or screening for contralateral breast disease in high-risk patients. Some future directions. This is a meta-analysis that was actually a podium presentation at EGSO in Florence recently, and you'll see, notice some of the authors that we all know very well. And so they were kind enough to share some of these results. This was a randomized controlled trial meta-analysis looking specifically at patients with early breast cancer planned for curative treatment. The intervention was preoperative MRI. The control was standard triple diagnostic assessment. And then outcomes, they looked at both surgical and oncologic outcomes. They evaluated breast conservation versus mastectomy, any shift from BCS to mastectomy and vice versa, re-excision rates, contralateral mastectomy rates, time from diagnosis to treatment, and then they also looked at local recurrence, disease-free survival, and overall survival. They included 6 studies, just over 3,000 patients. And what you can see here is that the patients who were amenable to BCS prior to or at recruitment prior to any intervention were just at 90%. And then post-intervention or post-MRI, this number decreased to 85.4%. And this was significant. Shift from mastectomy and contralateral mastectomy, you can see that there was an increase in contralateral mastectomy for patients in the intervention group. The other thing we need to think about, and this is true, and anyone who orders MRI, you have seen this, right? We order the MRI, inevitably we're going to get something that comes back that then needs additional biopsy or workup, and that's going to delay the time to surgery. And this, as surgical oncologists or oncologists, we need to really be thoughtful about that because we don't want to delay it significantly. And what they did see is there was a substantial delay for patients undergoing the treatment arm or the MRI. And it was significant. And then finally, thinking about oncologic outcomes, there were no differences in local regional recurrence, disease-free survival, or overall survival that were significant. So the data from observational studies that we know about, so invasive lobular and reoperation rates, so far we don't know of any differences. Multifocality, there's no dedicated studies, but certainly inconsistent reporting. And then in the post-neoadjuvant setting, we've talked earlier, there are higher mastectomy rates, but not necessarily higher accuracy. So in conclusion, the meta-analysis of randomized controlled trials have not verified that MRI can reduce the extent of breast surgery, reduce reoperations in patients undergoing breast conservation, improve local regional survival, disease-free survival, or overall survival. And the patient population that is included in the randomized controlled trial may or may not reflect the usual MRI candidate. Observational studies can't consistently verify any benefit in the usual MRI candidate, so that is a limitation. And in the absence of clear and precise clinical questions, MRI may be more of a troublemaker than a problem solver. Indications need to be individualized and really based on tailored clinical questions. So again, decision of MRI needs to be made adjuvant to the clinical exam, mammogram, and ultrasound with a specific clinical question. MRI, again, is associated with higher false positive findings, which can increase patient anxiety, leading to additional biopsies and overall patient cost. MRI may help reduce re-excisions in some subsets, but the cost may also be increasing the overall mastectomy rate. MRI has not been shown to reduce local recurrence or overall survival, and it has been shown to delay the time to surgery and treatment. Other future directions that certainly we want to consider and look at would be the evaluation of contrast-enhanced mammography and how that it compares to MRI. So thank you so much for your time and happy to take questions.
That's great. Thank you, Kristen. That's a lovely talk. I think we're so dependent on asking for MRI scans, and sometimes, as you say, it can cause problems. We should have got a radiologist with us. That's my fault. I did not get any radiologist online, but the people don't realize that not all MRI scan sequences are the same. What you do in the States is different than what's done in certain parts of Europe. And the diffusion part of it is also the whole thing is slightly different. And sometimes you get second opinions for people that were done in the States. And when they look at the MRI scan, they need to look at it from a different eye because it's a different sequence and different scan. Andreas, any comments?
Well, I think that everything is about interpreting the results correctly. Crystalline did a great job with that. I think that we should not go from here today feeling that we should never perform an MRI, but the idea is that it is really very, very important to have a specific clinical question to address when this is the case. This is what I think is key because you know, in everyday clinical practice, sometimes a radiologist might ask you for an MRI because it is a scan that they can review in their own time and comfort, or they could put a plugin like, you know, a CAD plugin that will do the job for them, if that makes sense. But this is something that is not always reasonable, and there have been some misconceptions. So, for example, doing an MRI on a preoperative diagnosis of DCIS to assess extent of surgery. We have a meta-analysis of observational studies 10 years ago that showed no difference. Now we have a dedicated randomized control trial, the IRSIS trial in JCO, that we included in this meta-analysis, where not only did they not demonstrate any benefit, they did a subgroup analysis to highlight directions, and they themselves said it's not worth looking at it anymore. It was very, very clear. And the first and last author, they were radiologists. They were not surgeons or oncologists in that. So I think we kind of need to consider that, along with the fact that when we do an MRI, it is a slot, and I'm not aware of any unit that has an indeterminate and endless access to the MRI camera. I think that the comment about contrast-enhanced mammography or, you know, 3D tomography with the use of AI, because we have seen very fascinating emerging data on that. These will give us answers, I think.
I think there's lots of role for CEM, and CEM is much easier to biopsy and more accessible to many places. It's not as expensive as an MRI scan. And in many parts of the world, that will be the answer. But also, when you have an MRI scan lesion that you cannot see on mammogram, ultrasound scan end up with an MRI biopsy, which will be in only certain centers, not everywhere, and cause more headaches. I love MRI scans, don't get me wrong. If I get MRI scan on every patient, I'll be happier. Sometimes it's an extra tool, but you need to be careful with what you get to use that tool for. You're not going to answer for an MRI scan just because you answer for an MRI scan. Ask for one. The problem, many times we ask for MRI scans when we have a problem, and it's not always a solution. Theo?
Yes, thank you, Christian. Very, very informative, very good presentation. And I think if you look at the take-home messages that I agree most with, then you know MRI is not useful in all patients for sure, and probably not in the majority of patients. However, there is one aspect that is not looked on these trials, and that's whether the MRI can inform on the oncological treatment, because maybe it does not for surgery in most of the cases, and this is what the studies have investigated, what they've shown. But again, I don't know. I don't think the question is answered at the study level or population level, but on the patient level, sometimes we are not sure about the effect of the neoadjuvant treatment. And today that we have more options and we could use some tailoring of the neoadjuvant treatment based on the response, then there are cases, and I have several specific patients in my mind where if you do an ultrasound, you don't see any changes, or maybe you see an increase in the tumor size during therapy, and then you do an MRI and you see that there's no contrast enhancement anymore, and this is like what is actually the case then when you remove the tumor. So I think there are some more unanswered questions, and I would suspect that there is a subset of patients that would benefit from MRI. Maybe contrast enhanced mammography can also substitute these cases, but we don't know that.
Also, we're depending on studies from 10, 15 years ago when they had the MRI scans are much better now. The technology keeps on getting better and better, and low field is coming in, high field is getting the different. People are trying to get the scanners, the new scanners are much better than the old scanners. And I think there's a role, but remember, we ask for it when you have a mammographically occult tumor. We ask for it when you really cannot delineate the extent of your surgery. We ask for it in many of the uh, post chemo and chemo patients. We ask for it for lobulars, and in the past we used to ask for it for every lobular, and then they started arguing now if you have somebody who's a BIRADS A or B, you're just looking for you might just really omit because you're not doing anything for the other side. So the indications are a bit fluid and keep on changing, but we don't use it for the straightforward cases, and that's why we get more problems with it sometimes. Andreas, you have your hand up, so I need to tell
Yeah, I would like to let Crystalline comment first.
Oh, I was just going to comment kind of in the neoadjuvant setting. There are some things to consider with MRI. Like certainly, yes, it's nice when you don't see that enhancement when it enhanced brightly at the beginning, but you also have to think about sometimes you can get fibrosis, sometimes you can get extensive DCIS that's left in the cavity that may not actually represent invasive disease, and other inflammatory markers that can show up. And so even though we use it a lot clinically to base decisions, it's not always as accurate as we think. So I just wanted to put that caveat in there. I use MRI quite often for very specific clinical questions as well. So I don't want to think anyone to think I don't use it, but I do want to make sure that there is that clinical question.
Andreas.
So what I wanted to say is that I agree with Theo on this one. I think that this is an instrument that we have been using the way we have been using it out of reflex. I just think that further trials should kind of try to focus on what we have already learned from the past. Now, if we come to that point where we will be using the MRI in a similar manner in which it is used in the I-SPY consortium, for example, because I'm guessing that Theo, you meant something like that, that you can, as you go, assess response and adapt, and that's the next step. And I think that this is where MRI will have its predominant role. That's the one thing. The other thing is that we can use it. There is a comment in the feed referring to the prospect study by Bruce Mann, which is a non-randomized study where they took very favorable cancers, ER positives of grade 1 and small size, and they did an MRI to make sure that there was nothing else in the area to make the decision to omit radiotherapy. So if we are using it in order to make things less complex, yes, but we need to learn from almost the beginning when we should be doing that. And still, it looks as if biology is king. So it is biology that kind of, leads to our decision on that, I think.
Also, people, please fill as much as you can on the polls. We have just over 200 people that filled the polls. There's more than 400 people online. And if you can put a comment on the fourth question, that will be fine. That will be great. Another comment, Andreas, biology is king is not only in terms of management as in treatment, it's also in terms of investigations. And so,
Exactly. That's what I meant.
and so we need to also remember that there are certain biologies like lobular MRI scan is great for that. There's certain biologies like DCIS. Sometimes we end up doing an MRI scan because we want to know anything, and it is usually not useful. In certain cases, in high grade, it might be, but not always. So we just need to be careful where we use it, because sometimes if you use the wrong tool in the wrong setting, you get the wrong answer.
I just think that, when we reach the point in which radiomics will and translational research will allow us to be able to interpret imaging during the course of primary systemic therapy, for example, to be able to make decisions. I would just refer to the Train 3 study, for example, where they had an MRI-based de-escalation of systemic therapy as they went after the second cycle. This is great, but the point is that this is where we need to focus, and this is how we should start thinking about things.
And that's
That's my
We've done a
point.
bit of work in Aberdeen where we used to do MRI scan after the first or second cycle, just looking for certain things specific, like lactate, like also lipid composition, and sometimes that can give you answers, but that's not in clinical practice yet. Now, I think we need to close the MRI scan discussion. We don't have a radiologist with us, which is a shame today. Any final comments about the MRI scan?
I was just going to make one comment about some of the comments in the chat, and thank you for sending those in. But I do want to reiterate, if you have a patient who's otherwise high risk or has really extreme dense breast tissue, it is an excellent tool to use.
So yeah, Barrett's C, Barrett's D, mammographically occult, lobulars. There's lots of indications for it. We are not trying to say don't use MRI scans. It's a great tool, but just use it in the correct context. Am I correct in saying that?
Yes, there is a nice question. Thank you, Dr. Gallagher. How much do your radiologists like you?
I have seen that. Thank you, Kristen. It's a lovely talk. And now we'll go to Leela. We've bored Leela, and it's her time now to give us talk about HRT. Also, again, we're not trying to scare people of using HRT. It's just data. Have a look at data and have a little discussion about the data that Leela has found. And I'm going to do the poll, but let me just see which is the pre and which is the post. So this is the pre-poll. And if I launch this, oh, the poll result is being shared. I'm still learning on those polls, so just bear with me for a minute. You can start sharing your slides, please, Leela, until I sort out my mess here. I don't know what I've done.
I am on slide sharing. You can see. Let me try again.
I'm not on that screen.
Okay.
So don't worry about me. I'm just somewhere else on the computer.
Perfect. Okay.
You are sharing slides. Yeah, it's not you, it's me. So
Okay. Fair enough. Love to hear that.
Now it's the so perfect. So topical estrogens in ER positive breast cancer. So patients that had breast cancer, ER positive breast cancer, they just need some vaginal or topical estrogen. How comfortable are you with using that? Is it part of clinical practice to prescribe that for patients, or even advise them, not necessarily prescribe, advise? Is it yes or no or a yo? And do you believe that it's oncologically safe in patients previously treated with ER positive breast cancer? That will be good to know about your thoughts about that. And do you feel that anti-hormonal therapy like AI versus tamoxifen will make a difference to the potential HRT risk, if there is any risk? So if somebody is on tamoxifen or somebody is on AI, and most of the patients will be on AI if they need topical estrogen, but if somebody is on tamoxifen, will you be a bit more comfortable with that or not? So that's the poll, and you'll have the poll after. So if you can answer as much as you can, that will be great. And Leela will start her talk now.
Hi, everyone, and thank you so much for having me today. Full disclosure, I'm coming from a gynecology point of view. I am not a breast surgeon. I'm in training for gynecology. And this question is a quite regularly encountered question, especially in the menopausal clinic, where women may or may not receive topical estrogen for very, very frustrating symptoms on the basis of whether they are on estrogen treatment, on endocrine treatment. And coming from that, a little bit of background, even though I don't think any of you needs this part of the story, but endocrine treatments are the adjuvant therapy choice for hormone receptor positive breast cancer. And these agents, unfortunately, are associated with quite a high burden of menopausal symptoms. These can also affect drug compliance to a degree, and therefore can become a headache for the treating team. Topical estrogen till present had been essentially taken as the most benign option, given the fact that it's topical, and therefore it's presumed to have reduced systemic bioavailability. However, more evidence is now coming into light, suggesting that, especially if a woman is perimenopausal or postmenopausal, the topical estrogen is taken much, much faster into systemic circulation rather than in premenopausal women, especially in the context of how the body reacts to it. And the present study that essentially had lots of people on this panel, led by Prof. Alahis and Prof. Karakatsanis, aim to evaluate the strength of the evidence, if there are any, on the basis of the risk of recurrence and mortality when topical estrogen is utilized in congruence with tamoxifen or aromatase inhibitor treatment, obviously in breast cancer survivors. So this is part essentially of the systematic review. We searched 6 databases, 2 prospective registers, and at the end of the day, I'll save you the details. We reached to 6 observational studies that were deemed eligible for inclusion. The main outcomes were risk ratios in order to make these results more clinically applicable. And as you can see, and I think this is the first part that I really want you to focus on, we also did a grade analysis on the certainty in evidence per outcome. And whilst we have 2 arms, the recurrence outcome arm and the mortality outcome arm, and for the first 2 lines, you can see that it's tamoxifen and aromatase inhibitors. We do not make a separation on how these patients have been treated. The actual certainty in evidence is high. When we break down to recurrence on women that have been treated with aromatase inhibitors versus tamoxifen, the certainty in evidence is low. And it's low because we don't have enough studies. We do not have a big sample size where we can actually confidently say, yes, this increase is true and is there. But as you can see, there is already an increase in terms of recurrence for women that have topical estrogen and aromatase inhibitors. The same is not observed for tamoxifen. And in terms of mortality, you can see that actually we have either moderate or high certainty in evidence and not a statistically significant difference between the ones that are concurrently taking topical estrogen. Now, in terms of the cohort, we in total had 38,000 females. And I can hear you already thinking in the background online, well, that's a pretty reasonable number. However, remember that the vast majority had not been exposed to topical estrogen. So these were kind of the controls of each arm. The median age of the participants was 61 years old. We had a follow-up to recurrence for 7 years, a follow-up to mortality for 10, and the median exposure to topical estrogen was 1 year. And as you can tell, the topical estrogen is not really a selection choice for the ones that are 60 and above. And there was a clear risk stratification for the women that were much, much earlier and closer to the perimenopausal sort of window of opportunity. And what did we see? So 5 studies that were exploring the recurrence rates. And when we had combined all the endocrine treatments, not a significant difference between the ones that had topical estrogen versus the ones that didn't. However, when we came down to the ones that were only exposed to aromatase inhibitors, you can clearly see a statistically significant increase in the risk of recurrence in the ones treated with aromatase inhibitors. We also did sensitivity analysis on the basis of the Newcastle-Ottawa scale. So technically how good in terms of grading was a study that was included, the cutoff of over 5 years from follow-up, studies that had over 40% of the population being diagnosed with positive lymph nodes, and the studies that had premenopausal breast cancer patients. And for each of these subgroups, the findings were not really altered. Now, in terms of mortality, We had 4 studies exploring mortality in breast cancer survivors. And in terms of the 2 arms of endocrine treatment, either aromatase inhibitors or tamoxifen, plus minus topical estrogen didn't really affect the results. However, in terms of the sensitivity analysis, for the women that were diagnosed with positive lymph nodes at the beginning, it didn't really matter whether you given topical estrogen or not. The all-cause mortality was significantly increased, regardless of endocrine treatment of choice. Now, how we were to solve this conundrum of have we actually reached enough numbers of patients or haven't we? We did a trial sequential analysis to actually identify which are the appropriate numbers to make any recommendations in terms of sample sizes for women on either tamoxifen or aromatase inhibitors plus minus topical estrogen. And overall, the numbers were reached. However, there is a very small conundrum that actually changes significantly how we interpret these results. This analysis only essentially targets on have we reached enough numbers? It doesn't really examine whether the population is homogeneous enough, therefore whether we have inherent confounding factors that could change the outcome. And therefore, we took these results to a panel of experts to essentially let us know what their perspective and what their take on the results was. So essentially, first off, we asked them, would you prescribe topical estrogen? And the vast majority said yes. But then we posed additional questions, and this comes down to Yazin's and Andreas's amazing poll system today. How would you risk stratify which women you would actually prescribe topical estrogen? And 35% of the panelists felt that if you had advanced tumor stage or aggressive tumor biology, or you were under 5 years from breast cancer diagnosis, they wouldn't prescribe topical estrogen. Additionally, we cannot just say to women, look, I'm not going to prescribe topical estrogen. The first question that they're going to ask in a menopausal clinic is then what? Is it just deal with it kind of approach? The vast majority of experts felt that hyaluronic acid or water-based lubricants were another solution to that problem. And essentially, the vast majority felt that the specialty that should be undertaking this prescription should be the gynecologist. Coming from a gynecology point of view, I can tell you that especially in the UK, we have very limited information about breast cancer itself. We do not treat these women. We just see them in the menopause clinic. And we are not in an open sort of communication with breast surgeons and oncologists. And therefore, there is a bias not to prescribe from fear of. And fear of is primarily fear of lack of knowledge. So taking it further, we asked our panelists to identify strengths and weaknesses. And as the majority of you would be recognizing at this moment, they pointed out the low level of evidence, given the fact that we're coming from a limited number of studies that were primarily observational. And equally, they pointed out that there were unmeasured confounders, which was absolutely true. In the vast majority of studies, and actually in all studies, the brands of topical estrogens was not recorded, the concentration, the full duration of exposure, we just had a median, and alternative sources of estrogen were not recorded either. So fine, we do have possibly adequate data to suggest that there may be an increased risk of topical estrogen plus aromatase inhibitors for recurrence, but then we cannot base clinical judgment on the basis of that. And we brought to our panelists the question, how would you design a study that would pass the ethics board in order to answer this question? And the vast majority of our panelists felt that either a single arm non-inferiority study or a prospective observational cohort study with homogeneous cohorts, and that kind of leads back to the trial sequential analysis, would represent a viable alternative solution. So take-home messages: potential increased risk for recurrence, but not for mortality when topical estrogen is with aromatase inhibitors given, the estrogen prescription can be reviewed on a case-to-case basis, and this comes down to patient-informed consent. Tumor-related factors such as advanced stage, aggressive biology are noted across the expert panel to preclude topical estrogen prescription, and the alternatives would be a hyaluronic acid-based formulation. And the last take-home point from this is that we truly need a comprehensive and multidisciplinary educational material, and that comes to from the gynecology point of view to the breast surgeons. We do really need a team approach for this, essentially across an interdisciplinary spanning problem. And that's it. That was my talk. I hope you found it interesting, and special thanks to all of our panelists and my mentors who are currently here on this panel. Therefore, thank you.
That's great talk, Leela, and that's just up to the point. So I will launch the other poll, but we'll start the discussion. And any comments from, let's start with oncology. Any comments from Antonius or from Theo? No comments about use of topical? For me, for example.
Well, Antonius asked he did his comments when we were writing the paper.
So for me, I feel comfortable giving a short-term topical vaginal estrogen for patients, even if they're ER-positive breast cancer, because at the end of the day, you're increasing a small risk. If you're increasing it, if you argue that you're increasing risk, you're increasing a small risk. So that increase might not be significant enough. As long as there is informed decision making, as long as this is going to be reviewed, and as long as the patient understands what we are talking about, and that there other options have been explored, because at the end of the day, it's about quality of life. Theo.
Yes, a comment I have, looking at the meta-analysis, I think there is a clear signal that patients on aromatase inhibitors we're not totally confident in giving them topical estrogens, and it's not very easy to show. You need the meta-analysis, probably you need even larger studies to show that, but you can't ignore the signal that is there. And my pragmatical approach to this is that this old trial, the big 198, that compared letrozole versus tamoxifen or a sequence. And that is one of the studies that has led to our using aromatase inhibitors in the first place, and so extensively today, especially when they're not patented. But in that study, there were the sequential treatment arms, and if you look at the first report, patients that received 2 years of letrozole then switched to tamoxifen. They had exactly the same prognosis as patients that were on letrozole monotherapy. And this, the drug was patented at that time, and it felt like that this information was just hidden at the corner of the paper, and it was not followed up. But even the long-term follow-up, there was no difference between these two arms. And I think that the pragmatical approach to this approach, because we have a lot of patients with side effects of the treatment, I think we underuse the switch strategy. And so I think that when we have a patient with on aromatase inhibitors that has these side effects, the first step would be to switch to tamoxifen. This would solve the problems in some cases, and when it doesn't, then you can give topical estrogens safely.
I agree. And essentially the aim of this paper was to review what are the alternatives. And does a woman need to stay on aromatase inhibitors? And there's, as we've discussed before, it's the element of informed consent. So if you do know that your relative or your risk ratio is increasing by 2.5, what would you like? Do you want to switch to tamoxifen and then we can try topical estrogen? essentially touching upon the quality of life? Or would you like to continue take that risk on board, continue with the drug of choice currently and be on topical estrogen, or go for something completely different?
Antonios?
Yes, thank you. I would like also to give another aspect. I agree with Theo and with Lila about the possibility to switch to tamoxifen and see if the problem is solved. So you can give local estrogens. In general, we have only observational studies for now, so we cannot claim causality in this analysis. At the same time, when we look at the mechanism of action between the aromatase inhibitors and tamoxifen, we can see that there is a biological rationale that can support this issue of causality. So we need to think about that. And one aspect I would like to raise as well is that when we discuss with our patients and we say that, okay, we might have a risk, but we can try with local estrogen, even when we have a patient in aromatase inhibitors, we can consider the fact that we have different types of local estrogens with different potency in terms of how they can influence the receptor, let's say. So we can choose estrogens with low potency and lower doses if we would like to be safer.
I mean, the other alternative in terms of the formulation is higher viscosity in order to prevent the fast uptake and the systemic uptake. But essentially, the aim is to start true collaboration between oncology, breast surgery, gynecology, and obviously schools of pharmacy to provide better options for our patients. And I think this was the epitome of this paper, is bringing different people together rather than seeing a problem from the narrow perspective of one specialty.
And there's a comment online which I also agree with. There's lots of non-hormonal alternatives, and there is some newer hormonal alternatives. I'm sure that you'll be able to tell us more about that, Leela, that are not as absorbed, and some of them are also are not going to have the same effect like the Vagifem. So sometimes we will look for a current problem that might not be a problem in the future, if I'm not mistaken. Let's take Crystalline first, and then we'll go back to Leela. So we'll give Leela some time to arrange her thoughts. Crystalline.
Thank you so much. That was a wonderful talk. And I agree with many of the panelists as to what has already been said about, lowest dose, shortest time as possible, and really having that balanced conversation. At least in the US, I've had this come up in my clinic several times where patients come in and ask about other topical preparations, such as estrogen creams for their face and neck for cosmetic reasons. What are your thoughts on that? I know how I counsel them and at least have that balanced conversation, but I would love to hear your expertise.
So technically, if a mucosal surface, we have a higher vascularity in the pelvis, much higher and faster uptake. But if you expose any mucosal surface to topical estrogen, you can expect that a very similar absorption sort of rate is going to hit the systemic sort of estrogen levels. So we don't have any evidence in terms of topical estrogen for other reasons in other mucosal surfaces, but one may run into an assumption that you may have a similar outcome.
And we hear the term bioidentical HRT. What does that mean, Leela, for a simple breast surgeon?
Molecules that essentially function in the same kind of way, but they do not have structurally, only part of them is the same, the one that hits the estrogen receptor, let's say, or the part that hits one particular receptor. But overall, it doesn't have the same systemic effects. It doesn't have off targets.
For a simple breast surgeon, is that simply the answer?
Better. It's supposed to be better. It could be. It could be.
And it is
That
available
was
also
your
for a
fault
simple breast
asking
surgeon.
Leela about molecular.
No, we're not going to go there. Perfect. Now, any other comments? Please, everybody online, we have only 175 that answered the poll. Please answer the second poll. It will make a difference to us. And we'll keep on discussing only for a few minutes before we close the webinar. Any other comments from anybody
comment that I
else?
would like to make, the only comment that I would like to make is that the reason that I wanted this topic on a webinar for breast surgeons is that due to different practice patterns, this is a very common problem of our patients that not all of us are commonly exposed to. Usually for those healthcare systems in which the breast surgeon has little or nothing to do with the follow-up, and you have somebody who is miserable, but you see your incisions and you see your therapeutic mammoplasty or whatever, and you say, they should be very well. I have done a fantastic job here. I think that this is an important topic that we need to be aware of. Because when we are looking at quality of lives and patient experience, we see it in studies and clinical practice alike.
Yeah.
It's the small things that matter.
Yeah, it's the little things that matter. That's true.
Yeah, it is about survivorship in the end.
So I don't want people to get the wrong message. I don't want people to say that topical estrogen will increase the absorption a bit. And as Antonio said, we don't know about causality. Yes, it might increase the risk, but you're increasing a small risk slightly. So we need to have that balanced discussion. There's other options. I think in the clinical practice, you'll find lots more of those bioidentical type of HRTs that Lila talked about that will sort out the problem and will have more, but we need some more evidence to know about that. I usually tell the patients, let's try it for a short period of time. Let's see how things go. If that changes your quality of life, then we'll rethink about your hormonal treatment. But try it first. I don't think that a short course will make a huge difference. That's my approach. I might be wrong, but that's the way I do it. I don't know how the others do. How do you do it, Andreas?
So you see, in terms of system, in terms of healthcare system, this is a question that I'm not actually obliged to take up. I usually take up these questions myself, but this has to do with the fact that follow-up is, if you do not intentionally go through with it, it is quite generic. It is not part of how our guidelines suggest we need to do things. And this is my point. This is a survivorship issue, and these are the issues that become very, very big problem in the reality of our patients. Once we have told them, now you're healthy, you can move on with your life, just keep on the tablet every day.
And the problem is that most of the studies, I don't know, correct me if I'm wrong, Lila and Theo and Antonios, they did not define what is a short-term course or long-term course. Some people say it's 3 months, some people 6 months, some people will define it as a year or a bit more. So is there a cutoff to say this is a short-term course? It might be okay-ish, and this is a longer-term course that can cause more issues. Has there been a time scale that you've seen on the meta-analysis that has significantly changed things?
So the median exposure was 1 year across all studies. No, we do not have a risk stratification per duration, and that's because it was significantly underreported. And that is another part that we need to consider, that these results, and as we've stated, do not support causality, are for that 1 year median exposure. What happens under that, like 3 to 6 months, it could be much, much better. We could possibly completely do a pulsatile exposure if you'd like. And we don't know for how many years after you need to be off topical estrogen so we can give it again without increasing that risk.
Theo, Antonios, any comments? You're the clever people. I'm a simple surgeon.
Tony, the floor is yours then.
No, I agree with everything said. I mean, we need to think about the balance between, maybe the risk that we might increase a little bit and the symptoms and the quality of life of the patient. So this balance is important to think when you decide. Unity for the patient, as we said, clearly state the evidence, the problem with the evidence in an easy way, and then make a decision with the patient. Theo?
Theo, any final comments? Theo and Crystalline?
Nothing more to add. I think it's all said. Lack of
Kristen,
evidence in many of these questions, so it's hard to have a definite opinion.
Kristen, any final comments?
No, I mean, it's definitely something we should all be familiar with because it comes up regularly in the clinic. And, quality of life and survivorship, as has been mentioned before, is really important for our long-term patients.
Perfect. Now, thank you everybody for being online with us today. Next webinar, if you want to be involved in research, please attend the next webinar. So the next webinar, the 5th of April, will be with the EU Breast. It's a great group from Europe that runs lots of the international collaboratives. We'll have very similar to like today, not 3, we'll have 4 talks about 4 studies. One looking at prepectoral reconstruction, one looking at localization studies, one looking at granulomatous mastitis, one looking at seromas. Each speaker will give 10-15 minutes to talk about their study, and then we'll have some questions and answers, and you have the scope of joining us. So if you want to be part of that, I'll be sending the links soon, hopefully sometime in the next couple of weeks time. I'm still working on it. So many thanks for the speakers and for the panelists for being part of this and for giving up your time. And of course, thank you for the lovely Tatiana and for Ricardo Pardo. You've been great with the language channels. And thank you for people in the States and in South America. And have a lovely day. For people in Europe and the Middle East, have a lovely evening. For the people in the subcontinent and Far East, have a good night. Thank you everyone for joining today.